Today's forum is presented with the Center for Community Solutions as a special Spotlight on Public Policy forum and presented in partnership with Universal Healthcare Action Network, Ohio. We'd like to acknowledge a special guest today. Please join me in welcoming Mr. Terry White, retired CEO of Ohio's two largest Medicare providers and providers of care to low-income people, the University of Cincinnati Medical Center and Metro Health in Cleveland. Terry, it's a delight to have you here. And now we are excited to have the head of the American Cancer Society here in Columbus to talk about his book, How We Do Harm: A Doctor Breaks Rank About Being Sick in America. Please welcome to the stage Dr. Otis Brawley.
Oh, thank you very much. I'm not the head of the American Cancer Society, but I'm the chief medical officer, and got a few thoughts I want to give about healthcare in the United States. First, I'd like to shout out to my colleagues from the American Cancer Society who are sitting back there at the table, and I'd like to thank Mr. Andrew Campbell and Debbie Rosenthal for arranging this, and I'd like to thank the Columbus Metropolitan Club. This is truly wonderful. I grew up in the inner city of Detroit, and I grew up a University of Michigan Wolverines fan, and I never dreamed that I could feel so comfortable and so welcome in Columbus. Indeed, when I was first invited to come to Columbus and give this talk, I thought it was Columbus, Georgia. That's the Georgian in me. I now live in metropolitan Atlanta. So I want to talk to you a little about my book, How We Do Harm, and tell you a little about healthcare and talk to you a little about how we in the United States really need to work on not really reforming healthcare, but transforming healthcare, and we need to realize that there are a whole bunch of problems in healthcare that until we can realize the problems exist, we're not going to be able to tackle them. Let's go through some of them. Number one, some people consume too much health care, and that is unnecessary care is given. Some people consume too little health care, and that means that those people are harmed because they don't get enough health care. And ironically, the people who consume too much health care are frequently harmed because they get too much health care. We could actually decrease the waste in this country, and we could improve overall outcomes if we simply were able to be following evidence-based medicine, realize what the science says and apply the science, and sometimes that means accepting the science. We need to be orthodox in our applications of that science, and we need to be rational in how we practice medicine. You see, the politicians threaten us with words like rationing. They have the root of the word right. We need to be rational because much of what's going on in medicine today is irrational. I should tell you, having grown up in Detroit, I went to a Jesuit high school, and I was taught to think in what some people think of as weird ways. I was always taught to doubt things. I was always taught to categorize things as what I know, what I don't know, and what I believe. I was always taught that I should question what I think I know more so than anything else, because very frequently what you know is wrong, or what you think is true is wrong. Doctors especially have this huge problem of confusing what they know with what they believe. As I approach mid-career as a physician, and I'm a medical oncologist and an outcomes expert and epidemiologist, in the United States, medical care is fraught with overconsumption. It's really the greedy feeding the gluttonous, because many patients want to consume all this health care. And there's actually a subtle form of corruption going on in medicine that we all let go on. And whose fault is it? It's the doctors, it's the nurses, it's the hospitals, it's the hospital administrators, it's the lawyers, it's the politicians, it's even the patients and the patient organizations. We all let this little subtle corruption that's rooted in lack of appreciation of the science, lack of applicability of the science. I'm a big advocate for evidence-based medicine. One of the great problems that we have in this country is a lot of people practice faith-based medicine. I so frequently hear, I don't care what the science shows. I know this test saves lives. I know this drug is appropriate. I don't care that there's no scientific study to show that it works. And our history is filled with this. In 1894, Halsted, the chief of surgery at Johns Hopkins, told us how to do the breast cancer surgery. He did it called the Halsted radical mastectomy. It involved resecting the entire breast. You could count ribs in the OR going to the third level of lymph nodes in the armpit. A woman who had the Halsted mastectomy looked like a quarter of her chest was removed afterwards. She could never raise her arm higher than this, and she always had lymphedema, always had a swollen arm. That was the way you treated breast cancer in 1894. Actually, it was a very appropriate way to treat breast cancer probably into the 1930s. From 1894 through the 1930s, most breast cancers that were discovered were about the size of my fist in a woman's breast. In the 1920s, 30s, and 40s, with more appreciation of symptoms and so forth, many breast cancers were discovered that were the size of a ping pong ball or even smaller. As the size of breast cancers were discovered were smaller, this operation may very well have been too much of an operation. Doctors in the 1930s and 1940s who said, is this too much of an operation? Should we be doing something different? Many of those doctors actually lost their academic careers for questioning Halsted 20 years after Halsted had died. You see, medicine does not tolerate people asking questions. Medicine frequently is not willing to evolve. It wasn't until the 1980s that we had finally been able to do clinical trials to show that a simple mastectomy was equal to the Halsted mastectomy, and a lumpectomy and radiation was equal to the simple mastectomy, meaning women didn't have to have this incredible deforming surgery. For at least 40 years, we in medicine overtreated and really harmed women by our lack of being able to evolve with the science. And this is a theme that goes on and on. In my own career, we started doing adjuvant chemotherapy and bone marrow transplant for breast cancer in the early 1980s. And we did this because a couple of doctors from Boston said it was the right thing to do. And doctors from Boston are usually very smart, so we should do what they say, correct? There was no science to support it, but we started doing it. Women started suing their insurance companies for refusing to pay for this procedure. 10 state legislatures passed laws, the one in Ohio is still on the books, saying that insurance companies had to pay for this procedure. And bone marrow transplant got more and more popular throughout the 1980s and 1990s. Finally, in 1999, 3 studies were published back to back to back in the prestigious New England Journal, and they all showed that this procedure was net harmful instead of net helpful. Within 3 months of those 3 articles being published, 210 bone marrow transplant centers in the United States all closed. We had transplanted 65,000 women for breast cancer in the 1990s alone. There was scientific evidence that was beneficial to the hospitals and the doctors. There was no scientific evidence it was beneficial to the patients. This was a huge problem. Erythropoietin, drug developed by Amgen to stimulate red blood cell mass, quickly approved in the early 1990s as a treatment for anemia. It was FDA approved as a treatment for anemia caused by cancer chemotherapy. Doctors, hospitals, clinics started with Amgen and Johnson & Johnson's encouragement, using it to treat people who felt anemic. There is a difference between the scientific measurement of one's blood and that being anemia and feeling weak and anemic. But the drug companies helped us with commercials. Many of you saw those commercials where grandpa all of a sudden was able to play with his kid. It was never FDA approved for anemic feeling. It was approved for cancer chemotherapy-induced anemia. When further studies were done on this drug in the 2004-2005 era, we actually figured out that this drug stimulated tumor growth. Erythropoietin is miracle grow for cancer. Not a good thing to give cancer patients. Yet the companies went out of their way to find reasons, even outside the FDA indication, to encourage doctors to prescribe it. And by the way, oncologists make their money off of the markup on chemotherapy. We buy wholesale and sell retail. When I ran an oncology clinic, we actually saw seeing patients as a loss leader. We saw patients so we could make money giving them chemotherapy. Amgen actually did something very interesting with erythropoietin. At Walmart, they call it volume discounting. Amgen called it bundling. You see, if you were a 4-person practice in Atlanta and you used a little bit of erythropoietin, with what you paid and what you got to charge, you pretty much broke even. But if you're a 4-person practice and you used a lot of it, what you paid went down, what you charged stayed the same. And there were 4-person practices that were making $750,000 giving this drug out. When you can make $750,000 giving this drug out, what you start doing is you start thinking, can I justify giving this patient the drug, and can I get their insurance to pay for it? You don't think, does the patient need the drug? And this is a big problem. Mass prostate cancer screening is another big problem in American medicine, and it still is to a certain extent, although it's starting to die down. In my Forrest Gump life, I actually got to go to the White House apology for the Tuskegee syphilis experiment, where Bill Clinton apologized for the fact that for 40 years, a group of about 500 men in Macon County, Alabama, were lied to about medical issues. It's important, they were lied to and misled. 2 weeks later, I went to an American hospital, a very famous American hospital, and when you're the government emissary going to a hospital that gets lots of federal grant money for research, they put this dog and pony show on to tell you how great their research is. I was sitting there watching it, thinking about how it was like so many others I've seen, but I was sitting next to the marketing guy. Marketing people are evil. Okay. I'm sorry, I know there's some marketing people out here, but hopefully you've seen The Religion. This marketing guy was bragging to me about their business plan in prostate cancer screening. You see, they had been doing prostate cancer screening for the last 7 years at this hospital, and they had figured out that if they announce in 3 weeks they're going to so-and-so mall to do free prostate cancer screening, the announcement will generate collateral publicity. And he knew how much that publicity would cost him if he were going to go to the local NPR or the local newspaper to buy it. And he knew from that publicity the bump he was going to get in breast cancer screening from women who came to his hospital because his hospital cares about their man, the bump he was going to get in chest pain visits from men who would come to his emergency room with chest pain because they're doing prostate cancer screening. And when he got to the mall in 3 weeks, if they screened 1,000 men, his experiences had been, and his business plan stated, they would actually diagnose about 155 men with an abnormal screen. And he knew the demography of the mall, and from that mall, he knew that 10 of the 155 had insurance that his hospital didn't take. That was business for his competition, God bless them. 145 would come to him, and he would charge an average of $3,000 to figure out why they had an abnormal screen. And of the 145 they'd hit what he called bingo on. They had prostate cancer. And he knew the proportion would get treated with radical prostatectomy, the proportion would get treated with cryotherapy, the proportion would get treated with radiation. He really liked radiation because they got paid really well to treat with radiation. It gets better. He starts telling me if we screen 1,000 men at this mall, we are going to have X number of men who have difficulties with urinary incontinence, and diapers just don't do it. So if we screen 1,000 men, this is how many artificial sphincters we're going to sell and our urologists are going to implant. It was 1998. He was apologetic because his previous experience on how many men would have impotence to the point that they just needed something, that he didn't have that number. You see, they have this little penile prosthesis that they can sell and their urologist can implant. He didn't have that number and he felt bad about that. He's talking to me. I'm a smart guy. I asked him, if you screen 1,000 guys that weekend, how many people are you going to save from a prostate cancer death? He took his glasses off, looked at me like I was a total fool, put his hand on my shoulder, and said, "Don't you know there's never been a study to show that prostate cancer screening saves lives? This is all about making money." And I'm thinking, I have just had an audience with Lucifer. Mass prostate cancer screening, done by many hospitals, is a great moneymaker. Tremendous benefit to the hospital, to the medical community. The patients who got it, many of the patients who go out and advocate for it, the first study to ever suggest it was beneficial was published in 2011. And the science of that study shows that it benefits 3% of the men who are diagnosed and treated. The other 97% have a diagnosis of prostate cancer and side effects, but no life-saving treatment. Now, that's one study. There's actually 3 other studies that have been published that suggest that there is no benefit to prostate cancer screening. So the most optimistic is 3% of men who are screened and diagnosed actually benefit. Now, given this data, the truth of the matter is that a number of organizations, including my own American Cancer Society, have said, in the case of prostate cancer screening, it ought to be within the physician-patient relationship, and men need to be informed of the potential risks and the potential benefits, and every man needs to make a decision. That includes the American Urological Society, for example. A couple other organizations simply say, don't do it. The American Association, the American Academy of Family Physicians, the American College of Preventive Medicine, the U.S. Preventive Services Task Force, they say don't do it. But the ones that have a positive statement about it, they say men need to be informed and make a decision, and it's okay to say, no, I don't want it. By the way, the American Urological Association statement from their website, if I may read for a second, given the uncertainty that PSA testing results in more benefit than harm, a thoughtful and broad approach to PSA screening is critical. Patients need to be informed of the risks and benefits of testing before it's undertaken. The risks of over-detection and over-treatment should be included in this discussion. There's a group out there, and I name names, called Zero, the Project to End Prostate Cancer. They have a series of buses that were bought for them by Kimberly-Clark, and these buses go around to various malls. In Atlanta, every January, there's one of them that goes to supermarket parking lots. So when I'm driving to work, I can hear that the prostate cancer screening van's at the Kroger supermarket on the corner of La Vista and Druid Hills today, and it's open from 9 to 5. In the summertime, they go to state fairs. Wherever they go, they hook up with a doctor group that treats prostate cancer. They hook up with a local radio or TV station. They get lots of press telling men to go get screened. I actually went to visit one of these once. A lot of guys, by the way, standing in line to get screened for prostate cancer with cigarettes in their shirt pocket. But the folks doing the screening have no mention about risks and benefits, no mention about informed decision making. Their literature only talks about how prostate cancer screening saves lives or increases survival or other very positive things. No mention whatsoever about informed decision making. This is the kind of problem that we have in American medicine. Oh, by the way, why would Kimberly-Clark want to buy buses? They make Depends undergarments. I don't know if prostate cancer screening saves lives, but it sure as hell sells Depends undergarments. We've recently had a wonderful NCI study that shows that lung cancer screening with spiral CT saves lives. It shows that it saves lives in people over the age of 55 who have an extensive smoking history. Yet St. Joseph's Hospital in my own Atlanta has ads on their website and even some billboards that said, there's now an NCI-sponsored study that shows that lung cancer screening saves lives. Did you know that non-smoking women in their 40s can get lung cancer? And they then advise non-smoking women in their 40s who've lived in an urban area for more than 10 years to come get lung cancer screening. They offer lung cancer screening for $95. Now, what they don't tell you is that a quarter to a half of those non-smoking women will get called back for further studies, and their insurances will be charged between $4,000 and $10,000 to figure out in most instances that they don't have lung cancer. And keep in mind, we have no study to show that lung cancer screening saves the lives of people in their 40s. Upton Sinclair once said, it's difficult to get a man to understand something when his salary depends on his not understanding it. Unfortunately, that is a huge problem in medicine. Let me for a second bash the drug manufacturers. AstraZeneca has this drug called Prilosec, or had this drug called Prilosec. It suppressed acid. It was a wonderful drug. It was so wonderful, it made $6 billion a year in profit for AstraZeneca in 1 year, and they had one problem with it, and that was they only had 4 years left in the patent. And so they started this thing which, and God, this is the honest to God truth, they called it Operation Shark Fin. Operation Shark Fin was the Manhattan Project to find the next multi-billion-dollar drug. And they looked a number of different ways. Then they found a chemist who actually knew a little bit of law, and they asked, not to get too complicated, Prilosec is a huge three-dimensional drug, and it's what we call an isomer. Your hands are isomers. They're mirror images of each other. And the chemists actually refer to these isomers as left-handed and right-handed isomers in 3 dimensions. Well, the right-handed isomer of Prilosec doesn't do anything. It's inert. Your kidney does a wonderful thing. It urinates it away. The left-handed isomer of Prilosec suppresses acid. Well, what he did was, he did what your kidneys would normally do for you. He created a pill of left-handed isomer. And then he went to the patent office and he got it patented. And then he did a clinical study that my 13-year-old daughter would have told you the end result of. He did a randomized phase 3 study and showed that the active ingredient in Prilosec was equivalent to Prilosec. And with that phase 3 study, he got it FDA approved as being equivalent to Prilosec. And then he went to the marketing guys. I warned you about marketing people already. And he said, how are we going to make this into our next multi-billion-dollar drug? Well, the marketing guys say package it as a big purple pill. What are we going to call our next multi-million-dollar drug? Let's call it Nexium. Ladies and gentlemen, Nexium today is one of the 10 most prescribed drugs in the United States. And it costs at the local CVS or Walgreens $6 a pill. If you open the package and actually read the package insert that the FDA forces AstraZeneca to put in the pill bottle, Nexium is FDA approved because it has been shown in clinical trials to be equivalent to something that you can buy for 20 cents a pill. It is one of the 10 most prescribed drugs at $6 a pill, one of the 10 most prescribed drugs, and it's on the market because it is shown scientifically to be equivalent to something you can get for 20 cents a pill. 1/30th the cost. We frequently do irrational things here in the United States. We don't practice medicine in a rational way. We do things to make money, and rarely do we do things to benefit the patients. We may think we are doing things to benefit the patients, but we have this faith-based medicine thing about us that doesn't allow us to realize the realities. Over the years, we've overdone it with hysterectomies, with C-sections, carotid endarterectomies, coronary artery bypasses, tonsillectomies. I can't even say the word for putting those tubes in kids' ears. We overdid those things. Postmenopausal hormone replacement therapy is a great example of overdoing something and then actually putting down people who question. We were talking about Bernadine Healy earlier today at our table. Wonderful lady who ran the National Institutes of Health. She created the Women's Health Initiative to look at postmenopausal hormone therapy with postmenopausal estrogens. She was fought tooth and nail. Wyeth gave us Premarin in the 1940s. By the way, Premarin is pregnant mare's urine. They crystallized the estrogen out of pregnant mare's urine and made it into a pill. And that's what women took postmenopausally. Well, it had never really been tested in good fashion, so the Women's Health Initiative was going to test it. Everybody said, we've been doing this for 50 years. You're wasting taxpayers' money. Everybody kind of got quiet by 2003 when the Women's Health Initiative actually showed that we've actually been manufacturing breast cancer in American women by giving them Premarin with a progestin. About 5 to 10% of the breast cancers in the 1990s were man-made, or maybe woman-made, by postmenopausal hormone therapy. I do a lot of stuff with health disparities. Some people actually wonder, why is it that black women tend to have more aggressive breast cancer when they get breast cancer? It's actually an interesting, convoluted answer, partially. You see, black women very rarely take postmenopausal estrogens. And white women more commonly take postmenopausal estrogens. And postmenopausal estrogens causes a more benignish form of cancer. So a higher proportion of black women have the bad cancer because we didn't make the good cancer in them. We have done a whole bunch of things irrationally. Now, healthcare in 2010 in the United States cost $2.6 trillion. A trillion is a big number. 1 million seconds ago was 8 days ago. 1 billion seconds ago was mid-1974, about the time Richard Nixon resigned. A couple of us can remember that. 1 trillion seconds ago was 30,000 years before Christ. A trillion's a big number. We spent $2.6 trillion on healthcare in 2010, and we spent $1.1 trillion on food, including alcohol. $2.6 trillion is a huge number. If the American medical economy were its own country, it would be the 5th largest country in the world. We spent $2.6 trillion on healthcare in 2010, and they spent $2.56 trillion on everything in France in 2010. France is the 5th largest economy. For every dollar we spent on healthcare, for every dollar we spent in the United States, 19 cents was spent on healthcare. Now, the number 2 country for that is Switzerland, tied with Canada, 11 cents out of every dollar spent on healthcare. Our 19 cents out of every dollar is almost twice the number 2 countries. And if the last 20 years tell us what the next 20 years are going to be like, we're going to be at 30 cents out of every dollar spent in the United States spent on healthcare by 2030. Our economy will not sustain that. Our economy will start crashing to the ground as we get that big. By the way, our outcomes are not that good. We spend more on healthcare than any other country in the world, and our outcomes are not that good. We're 49th in life expectancy among United Nations countries. We can actually be kind of proud of that. We beat out Ukraine at 50th and Romania at 51. When we look at infant mortality, Cuba beats us out. When we look at white male life expectancy, we don't do very well. Switzerland and Canada, those number 2 and 3 most expensive countries, if you're a white guy, you're going to live to at least 78 years in Canada on average, 70 and 80 on average in Switzerland, 76 years in the United States. On a per person basis, we spend $8,400 per man, woman, and child on health care. The number 2 and number 3 countries, $4,400. Many of you people run organizations and companies. Your average cost for a healthcare policy for a family right now is running close to $19,000 in this country. If you were in Switzerland, it would be $11,000. If you could save $7,000 per family healthcare policy, you'd probably employ 3, 4, 5 more people. Instead of a 7% unemployment rate, we'd probably have a 4.5 or 5% unemployment rate. Healthcare costs are already suppressing our economy. We do not have good outcomes, and we're spending money like crazy. By the way, I mentioned Nexium. European Union would not give AstraZeneca a patent on Nexium. They said, you got that patent 18 years ago when we gave it to you for Prilosec. We are being irrational. We have a system where some people consume too much health care, others consume too little, and we could be much more efficient and we could improve outcomes if we just started getting scientific. Now, I'm supposed to warn you guys to come up with questions to challenge me in a little bit as I sum up. Last thing I'm going to point out to you is, talked about the rise in healthcare costs. What I did not factor in those rise in healthcare costs is the obesity epidemic. You see, we have a unique problem in the United States that does not exist in Canada, does not exist in Western Europe, and that is 15% of Americans were obese in 1970, and it's 35 to 40% today. And by the way, I'm talking about obesity, which is a body mass index greater than 30. Conflict of interest rules do not allow me to talk about the condition known as overweight. Among kids, by the way, we've gone from 4% of kids aged 6 to 11 being obese to 20% in 40 years. The combination of obesity, high caloric intake, and lack of physical activity is causing a tsunami of chronic disease in the United States, increasing rates of diabetes, cardiovascular disease, orthopedic disease, and cancer. It's actually going to cause a legitimate need for more medical care beyond the economic projections that I've just given you. I'm going to end by saying we need to be rational. We need to appreciate the science. We need to understand the science. We need to apply the science. We need to start calling out people who are being greedy and gluttonous and people who are selling us snake oil. And we need to start practicing medicine in a much more humane, reasonable way. We don't have a great deal of time left before this economy is ruined by this outrageous rise in healthcare costs that are fueled by this irrationality. We need to make our politicians speak up. We need to speak up. Patients actually need to say, why do I need this expensive drug? Isn't there something cheaper that's just as effective? All of us need to take responsibility, or else all of us are going to go down as the economy goes down. Thank you very much.
Thank you.
Well, thank you very much for a really stimulating, troubling speech, Dr. Brawley. It's CMC's proud tradition to take audience questions. We thank you in advance for asking questions and not making editorial comments. Please go to the microphone, introduce yourself, and ask your question. And we have a question.
Hi, Dr. Brawley. I'm Bernice Smith, and I'm going to do a little recap. You said too much, too little, overconsumption, evidence versus faith, Forrest Gump, marketing people are evil, and I just happen to sit with the American Cancer Society people. That's not good. My question has to do with making informed decisions. You mentioned flushing, so I'm going to go a little bit dirty. We know dogs sniff, and we know how they sniff. Okay, kids pick their noses, and they pick out things and eat it, and they give different expressions once they've eaten it. Wouldn't it be great if we as a society were teaching more of being aware of what our body does and the excretions that come from our body and how that says something about what's going on with our health? For instance, when it comes to education, these things could be taught at a younger age in elementary school, that number 2, number 1 should look like this, or you should do it so often. And if throughout your life you're more aware of all those things in reference to excretions, then you would be aware of your health.
Well, I don't know about excretions, but I would say awareness of health is actually something I wish we could teach better. And you're right, it starts at about 1st to 3rd grade. It involves awareness of exercise, awareness of what good diet is, what bad diet is. I get into trouble sometimes over the issue of mammography screening and breast cancer. One of the great problems is, for example, no organization has recommended the monthly breast self-exam for 22 years, but I still hear people talking about it, and I see TV stations advertising for it. If we actually were more educated about health, we would know that what does work other than the monthly breast self-exam is women being aware of their breasts, and women who, while dressing or bathing, who find a mass, then feel empowered and have the ability to go to a doctor and say, what is this? And I say that because in my book, I know many of you read my book, there is a woman in my book who actually felt a mass in her breast and watched it grow for 12 years. And these educational issues are definitely a problem. And
just one more thing, the Department of Homeland Security has see something, say something, wouldn't look before you flush, work for the medical industry.
Hello, Dr. Brawley. Andy Campbell here. I wonder if you could comment for me briefly on kind of the quality of life issue compared with the American fascination with the preservation of life at any cost.
Yeah. When I look at how people view things in the United States, I see regional variation. People in our big cities and people on the West Coast and East Coast are heavily into preserve life at all costs. People who live in rural America are a little bit more accepting of the fact that death is a part of life. And so we have patients who get sick who are from farmland in Missouri and Illinois, who are much more willing to accept that they should go to hospice where the goals are, keep me comfortable until I die. And people who live in the big cities need everything done. I've had people, I can remember one conversation I had with a woman in Cleveland about her father, and her father was, by anyone's estimation, dying. And I asked her if we could keep him comfortable and not put him on a ventilator. And she said, no, I want everything. And I said, everything reasonable? And she said, everything is reasonable. And that gentleman ended up on a ventilator, and we put a pacemaker in his neck down into his heart to keep his heart pumping, and we put him on pressors to support his blood pressure. And he eventually stroked out his thalamus, so we put him in this temperature-controlled water bed. And that's when I realized, as a 27-year-old junior resident at University Hospitals of Cleveland, I was sitting at this gentleman's bedside. He was totally gorked out. The only thing if you stuck a needle in him, he would groan. I was sitting at his bedside as a 27-year-old, and I was going to decide what his vital signs were going to be that day. I'd just turn up or turn down the Levophed, and his blood pressure would go up or down, turn up or turn down the pacemaker, and that adjusts his heart rate, turn up and down a couple of things on the ventilator, and I could decide how many breaths per minute he would take. I could decide how much of a breath he would take and how much oxygen he would take. And then I'd go to the thermostat on the bed, and I could determine what I wanted his temperature to be that day. And that poor gentleman stayed in that condition for about 3 months until he finally had a heart attack that we just could not bring him back from. But that, by the way, is typical, unfortunately, instead of atypical in our big cities, that we spend a lot of money on end-of-life care where we should be focusing on keeping the person comfortable, and we sacrifice keeping them comfortable in exchange for keeping their heart beating.
Next question, please.
I'm John Lowe. About 40 years ago, I read a lengthy article called Don't Get Sick in America. And it was a lot of the same kinds of things that you're talking about now, so obviously it's gotten worse. You mentioned some things we can do, but the forces that bring this about are very powerful, including like the drug companies. I'm wondering, are there any organizations or are there any places we can point to for some help or that we might get involved in that could help?
We need a culture change. When I say we don't need to reform medicine, we need to transform medicine. If you look at Canada or look at Europe, where outcomes in virtually every disease, by the way, when you measure outcomes appropriately, which is mortality rate and not survival from diagnosis to death, when you measure whether someone dies versus whether someone lives with the disease, when you measure them looking at mortality, the Europeans and the Canadian healthcare systems do much better. I've actually called our system a sick care system. See, if you go to France, Germany, or even Britain, which has some problems with its healthcare system, their focus is on how do we keep this person healthy. In the United States, our focus is on screening for this, screening for that. How do we give this person a diagnosis of illness so we can treat it? Instead of how do we figure out how to make money off of them by treating them, we need to figure out how do we make money off of them by keeping them healthy. That's the transformation that we desperately need. The drivers for that are going to have to come from the community. As long as patients are willing to accept what they've been given, that's going to happen. Now, there's in my book, which I don't want to push, I talk about a couple of organizations like the National Breast Cancer Coalition, where you've got breast cancer survivors who've actually gone and said, what is the science? And I sometimes have debates with people from the National Breast Cancer Coalition, and I sometimes am thinking at the podium and wondering, do they know their field better than I know mine? They're really good, and they question and they demand evidence-based care. That's how we're going to fix this.
Hi, I'm Melissa Fetterman. My question, I'm not sure if you've been following the new hepatitis C drug development, but there's a new non-interferon treatment. It's incredibly effective compared to older treatments, but it's very expensive. Our program focuses on people living with HIV. There's a lot of comorbidity. A lot of them are people who live or who use injection drugs. And these are folks who their insurance is paid for mostly by the public. So there's going to be a huge price tag, essentially, for taxpayers with this drug. On the flip side, my husband, for a living, helps bring biomedical interventions to market, and he'll tell me about the cost of clinical trials and why there's a reason these drugs have these price tags. So I'm wondering, first of all, what is the truth about that? And secondly, what levers do we have as a society for changing something like this? Thank you.
Almost all the very expensive drugs and interventions over time become cheaper. And the disparities go away as they become cheaper. For example, smallpox was a huge problem into the late 1960s, and the vaccine for smallpox in the 1950s was actually quite expensive, and it's become cheaper and cheaper now, and smallpox is almost totally eradicated in the United States. Or it is eradicated in the United States, and it's almost totally eradicated in the world. We need robust drug development. We need to realize that if there is truth out there, those drugs over time will get cheaper. We're going to have periods of time where things like the HPV vaccine, for example, which I'm a big proponent of, is going to be $600 a child. But over time, it will get cheaper as more people get involved and we understand more about how to make the vaccine and patents expire. So I think we should be patient for that. Now, one of my great problems is I see drugs that are very expensive in the United States, and the same drug, which is still under patent, is much cheaper in Europe. And I've yet to figure out why they're more expensive here than they are even across the border in Canada. I mean, I grew up in Detroit. You can go to Windsor, Ontario, which is just 15 minutes from the house I grew up in, and sometimes find a drug at 1/10 the cost you find it at a pharmacy in Detroit. I cannot understand that. I wish the drug companies could explain it to me, and I haven't seen anybody willing to.
Hi, I'm Chris Graves, and I work with WOSU Public Media. And could I have the rest of the time? How about an hour? I'm just stand there. I have a lot of questions. No, but something that has troubled me for some time is that it just appears to me that there are more cancers than there used to be. I don't
Okay.
remember growing up as a kid
Yeah.
knowing,
Yeah.
and now I just know a lot of people
Okay.
with cancer.
There are more cancers. I can tell you that in 1900, I have the numbers right off the top of my head for death rate. This is age-adjusted death rate, so they've mathematically been changed to take away the fact that there are more people who are over 60 and more people over 70 alive today than there was 50 years ago, than there was 100 years ago. There were 63 deaths for every 100,000 Americans in 1900. That peaked at 215 deaths for every 100,000 in 1991. And we're now at 2010, which is the last year we have data. We have about 170 deaths per every 100,000. So that's death rate. So what you had was a tripling of the death rate from 1900 to 1991 and about a 20% drop from 1991 to now. That's age adjusted. That means a person's risk of getting cancer and dying from it in 1991 was almost 3 times their risk in 1900 for a person of the same age. Okay? Since 1991, a person's risk of dying from cancer has gone down by 20% for a person of the same age in 1991. So yes, increased risk, all right? Second thing that you're noticing is there's more people alive today who are over 60, more people who are alive today who are over 70. Median age of a cancer patient at diagnosis in the United States is 67. Median age at death is 76. So we got those two things going on. More people are getting cancer, and there's more people alive to get cancer.
And getting more cancer, environmental? Is it
No.
our own eating and drinking and smoking and all that? Why?
Okay.
And then I'm done.
The reasons why people get cancer, the third reason is actually going to really upset you. The biggest environmental cause of cancer in the 20th century was tobacco usage. People didn't smoke very much in the 1800s, and there's all kinds of data on how the cigarette-making machine, which came to us in 1890, increased people's risk of getting cancer and that sort of thing by making cigarettes cheap and easy and so forth. That's number one. In the last 40 to 50 years, this obesity diet thing, many people don't realize that obesity, lack of physical activity, and high caloric intake, it's a three-legged stool. It's not just obesity, it's high caloric intake and lack of physical activity. That's the number 2 cause of cancer in the United States. Actually, with smoking rates going down in another 20 years, it's going to be the number 1 cause of cancer in the United States. The other big driver, we can diagnose things now that we could never diagnose 20, 30 years ago. And some of the cancers that we're starting to learn that we're diagnosing now are cancers that never would have reared their ugly head and bothered the person 50 years ago. In other words, I'm trying to change I'm trying to change how people think of cancer, because 20 to 25% of cancers that we diagnose and treat, those patients didn't need to be treated and don't need to be cured because those cancers were never going to kill them. Now, I'm not advocating, except in a few cancers, that we diagnose people and then watch them. In a couple of cancers like prostate, that's sometimes appropriate. In breast cancer, 20% of the women who are diagnosed with localized breast cancer, the worst thing you can do is tell them they have breast cancer and treat them, but we do it because we know if we treat all those women, we're going to save some lives that needed to be saved, even though we treat some women whose lives were not in danger. And right now, we don't have a test to say, Mrs. Smith, you got breast cancer, but it's the good kind, have a nice day. Mrs. Jones, you got breast cancer and we need to treat you. I'm sorry, long-winded answer. Yes,
very,
sir.
very quickly, let me certainly commend you on your brilliance and your courage.
Thank you.
I served in the General Assembly for 24 years and created the first commission on minority health, and so now we have a number of them, as you well know, across the United States and in Guam and Puerto Rico, about 49 of them actually. I would like to have one recommendation.
Sure.
And I would like to take something back to the Ohio Commission on Minority Health, which they would share with other such agencies across the country. If you were to say, here's one thing that you should be doing, what would that one thing be?
It would vary from community to community. In the African American community, the Samoan community, and the Hispanic community, we need to focus on this diet thing. I mean, 50% of black adult women are obese right now. We desperately need to focus on this diet thing. I'm not speaking as a cancer doctor, all the chronic diseases, diabetes and heart disease. If I were going to focus on one thing, and if I were going to try to do one intervention, I would try to forcibly get every person to know, I need to eat 5 to 9 servings of fruits and vegetables per day. I go to Mississippi, where the average consumption of fruits and vegetables is 3/4 of a serving per day, and people think French fries is a vegetable. But that's the one thing I would focus on now. The next thing I would focus on would be smoking, because while 20% of Americans smoke, and it's 10% of Americans living in Utah, and it's 10% of people living in California who smoke cigarettes. That was a joke, guys. It's 20% across the country, but among people below the poverty level, it's 30%. Irrespective of race, it's 30% of people below the poverty level smoke. So I would do diet and smoking, and prevention starting in grade school or before is actually a lot cheaper in the long run than treating someone when they're in their 50s and 60s.
Thanks much.
Dr. Brawley, Susan Ackerman with Center for Community Solutions. As you know, in our healthcare system, both price and quality information is not transparent, particularly for the consumer. What advice would you give to finding a doctor who actually practices evidence-based medicine?
That's really good. And you can really get messed up when you're trying to look for quality. For example, when Bill Clinton needed a coronary artery bypass, and he actually needed a coronary artery bypass, he went to Columbia to get it, Columbia University. And the state of New York publishes the outcomes for coronary artery bypass for every hospital that does it in the state of New York. And Columbia has the worst outcomes. And they ask, why did you go to the place that had the worst outcomes? And you knew they had the worst outcomes. And he actually had someone who had done his homework, you see. Columbia has some wonderful cardiothoracic surgeons, and even I'll put Dr. Oz in that group. And they operate on some of the most difficult cases. Some of the other hospitals, in order to buff their numbers in the state registry, will send their bad cases to Columbia. Okay? And so he was able to look past the raw data and realize that the real quality was at Columbia, whereas the common man, even the common doctor, might look at the raw data and think Columbia was the worst place. Okay, so this can be very difficult. It was close to his home also. That's true. But yeah, his office is in Harlem, right down the street. I think I've always told people, try to understand your disease. If you have a chronic disease, this is easier than if you have an emergency. Try to understand your disease as much as you possibly can. Read from a number of sources, realizing that some of the things that are on the web are just outrageously wrong, but be able to try to refine those things and ask questions and try to learn about your disease. Try to have a conversation with your doctor and your doctor's staff. Try to learn about their philosophy of your disease and learn about your disease from them. Unfortunately, you don't frequently have time to have conversations with doctors, so this can be really difficult. And then go with your gut feeling. Get a second opinion on really important things as well. But ultimately, you need to go with your gut feeling, but have a healthy skepticism. So many patients show up, even when I have patients who get upset that I'm actually trying to explain to them their disease. I have patients who show up and say, just do it to me. And that's a real problem for many patients. They don't want to learn about their disease. Thank you so much. You've been wonderful.